My next talk's on optic neuritis. This is one that, again, is not that unusual of a clinical question that walks into my office, and certainly patients with vision loss from optic neuritis are highly likely to present to the eye doctor. This is something that I think would be valuable for all of us to maybe review together. I have no pertinent disclosures to this talk as well. I wanted to describe optic neuritis as a clinical entity, and I wanted to review a differential diagnosis to think through when faced with a potential case of optic neuritis. I wanted to review features of optic neuritis or an inflammatory optic neuropathy that I view as quote-unquote atypical and maybe would prompt a more extensive investigating of the patient. And then we'll go through a few case examples to, I hope, highlight those concepts. Optic neuritis, the term optic neuritis itself really is referring to a pretty small spectrum of patients that have inflammatory optic nerve disease. So when we say optic neuritis sort of conventionally, we're really kind of referring to the young adult patient of European ancestry, the North American residents, or something along those lines, who experiences an acute onset of painful loss of vision that's unilateral in nature, that then resolves spontaneously with relatively good visual outcome over a period of a few weeks. That's what we're talking about when we say optic neuritis. And so I like to, of course, think about that as being sort of a subcategory of a larger umbrella term of inflammatory optic neuropathy, of which there are numerous examples. Optic neuritis, however, at least in our country or our continent, is going to be the most likely entity you encounter when you have a young adult with an acquired optic neuropathy. It's up there, if not the most common, it's certainly one of the most common things you're going to encounter in that patient population. Patients with this condition will describe pain behind the eye or around the eye that may accompany or precede vision loss by a day or two. The vision loss could be anything ranging from dyschromatopsia to loss of contrast sensitivity. Usually there's some degree of lost visual acuity, and usually there's a demonstrable visual field defect, most often being diffuse depression of the visual field, or perhaps a more localized variety like a central scotoma or an arcuate visual field defect. Kind of by definition, there should be an RAPD, otherwise it's hard to really make a good argument that it's an optic neuropathy. However, someone with bilateral optic neuropathy may not have an RAPD, they may just have bilateral symmetric afferent defects. Most patients with optic neuritis, again, this sort of subset of inflammatory optic neuropathy, have a benign ophthalmic exam. There may be no findings at all. You just have evidence of an optic neuropathy without any other findings. So there's no uveitis, there's no optic nerve edema, there's no retinal vascular sheathing, there's no vitritis, there's just nothing. But they have reduced vision with an RAPD and dyschromatopsia. This entity in particular in our country and in Europe as well can often be the heralding manifestation of a demyelinating condition like most notably multiple sclerosis, or sometimes it can be a sign of a condition similar to MS, and we'll talk about a few of those. So what I described to you now is what I would label as sort of a typical optic neuritis. So the patient comes in, it's a young adult, probably of European ancestry, and they have reduced vision in one eye that's painful. It started over a period of hours to maybe a day or two before reaching its nadir. Sometimes they can have a little bit of progressive worsening over about a week or two, but it's usually pretty rapid in onset. And then you really don't have any abnormalities that you see on the eye exam. That's what I would categorize as kind of a typical, oh, this is just kind of garden variety optic neuritis. What I would view as atypical, or things where I would say, it seems like inflammatory optic neuropathy, but what else could this be? Is this something more unusual? Would be a patient coming in with vision loss, optic nerve swelling, but a lack of pain. That kind of a patient, I think about other problems, like whether that be ischemic optic neuropathy, compressive optic neuropathy, maybe a really rare person young adult who comes in with labor hereditary optic neuropathy, where they have a central scotoma, loss of acuity, but no pain. So lack of pain, I think, is kind of a pertinent negative to expand your differential diagnosis. Patients with protracted pain or protracted vision loss, in other words, you're seeing them maybe as a tertiary care center referral, or it took them a while to get in to see an ophthalmologist and it's been 2 months and they still haven't improved. That would be unusual for the classic kind of optic neuritis that we think about. Patients with a really, really prominent feature of optic nerve swelling should also be a sign of something going on other than your conventional optic neuritis. Patients with uveitis, certainly any sort of AC reaction, vitritis, pars planitis, things of that nature should be viewed as unusual, acknowledging that multiple sclerosis can produce those findings, but so can a lot of other things, including infectious diseases. Bilateral disease, I think, is a big red flag that maybe I'm dealing with something unusual here. I will say children or the pediatric population with optic neuritis can have bilateral disease pretty commonly, but in adults, that's pretty unusual. Also, getting back to optic nerve swelling, children with optic neuritis can also have a prominent feature of papillitis as kind of their clinical picture, whereas in adults, that's less common. Bilateral disease makes me think of more diseases like neuromyelitis optica, anti-MOG antibody disease, potentially things like vasculitis or different autoimmune disease like sarcoidosis. Other cranial neuropathies being present in addition to an optic neuropathy should be a red flag that this might be an orbital apex process. And when I think of orbital apex syndrome, I think of things like invasive fungal sinusitis, such as mucormycosis or aspergillosis, especially in an immunocompromised patient or a diabetic. I've also seen cases of nonspecific orbital inflammation producing this sort of a picture, or even I've seen a case of granulomatosis with polyangiitis creating this picture. Severe vision loss to the point of NLP, while it can certainly happen with conventional optic neuritis, that's always something we really like, wow, this is NLP, this is the real deal, and what do we need to think about? I would again think about things like neuromyelitis optica for profound, especially profound and protracted vision loss. And although this isn't a bad thing, a rapid response to steroids actually, by rapid I mean like within a matter of a day or two, they're getting better, in a way kind of tells you that while that's good, I mean we want our patient to get better, that might not be your typical MS-related optic neuritis. That could be something else, like sarcoidosis or MOGAD. So with this in mind, I was just going to kind of get through a differential diagnosis with you. This slide, I apologize in advance, has a lot on it, and I'll try to highlight at the end what I think about, at least in my neck of the woods. But the differential diagnosis for inflammatory optic neuropathy is extensive, and this certainly doesn't include everything it could be. But these are the things I run through and think about. So in terms of autoimmune diseases, I like to think about it in terms of things that have seropositivity or things that have seronegativity. So things that are seronegative, in other words, there's no blood test that'll be the diagnostic test. Things like multiple sclerosis or just kind of isolated idiopathic optic neuritis, and that small subset is what we're referring to when we say typical optic neuritis. Those are seronegative. There's no blood test. It's largely just a clinical diagnosis and maybe based on neuroimaging findings as well. There's a disease called CRION, or a condition called CRION, chronic relapsing inflammatory optic neuropathy, where patients have repeated episodes of optic neuritis or inflammatory optic neuropathy that's exquisitely responsive to steroids, and yet they just have episode after episode after episode with no identifiable etiology being found. And patients can also have a post-vaccination inflamed optic nerve. Seropositive optic neuropathies, I've only listed a couple. There are a lot of other examples, but the two that come up in my mind very frequently, and I think we should all be aware of, are neuromyelitis optica spectrum disease and MOGAD or MOG antibody disease, myelin oligodendrocyte glycoprotein antibody disease. There are others, but they're esoteric and very unusual. I think these are the ones we should all be familiar with. Lastly, you can have granulomatous diseases like sarcoidosis, GPA or EGPA, formerly known as Wegener's, and I believe Churg-Strauss. So I run through those in my mind if I'm dealing with an unusual situation. As far as infectious entities, we always should be thinking of syphilis, and I think Bartonella, especially neuroretinitis in the early phase, where you maybe don't have the classic macular star, Bartonella comes up. And in patients from endemic areas or outdoorsmen or people that might be prone to tick bites, I think about Lyme disease. Viral diseases, I've listed just a small number here. Viral diseases of many different varieties can create inflamed optic nerves, but the ones that come up, in my practice at least, tend to be herpetic viruses. You should also think about patients with HIV being prone to either a primary optic neuropathy from HIV itself or an opportunistic infection taking advantage of the AIDS status causing optic neuropathy. So I often check patients for HIV status if I'm thinking they might have an infectious disease. In terms of other, regions of the world, you could also think about mosquito-borne illnesses like dengue fever or chikungunya, which can also be reported to cause optic neuritis. And so depending on your region of the world, you might consider other entities. Tuberculosis is another one. Again, you should think about if in the appropriate context. And lastly, there are rare examples of protozoal illnesses causing optic neuropathy. Other kind of rare things that come up could be paraneoplastic optic neuropathy. You can have drug-induced inflamed optic nerves, most notably from immune checkpoint inhibitors, which are being used with increased frequency for cancer. Also, tumor necrosis factor inhibition can be associated with optic neuritis. And then there are mimickers. I talked about this in my last talk, that papilledema could certainly be something you could confuse with bilateral optic neuropathy or inflamed optic nerves, compressive optic neuropathy, ischemic optic neuropathy, radiation necrosis. And then lastly, functional vision loss. Could this patient be having non-organic vision loss? That's usually somewhat easy to figure out with a lack of other findings. So I highlighted the ones that tend to come up, at least in my neck of the woods, that I really think about or routinely test for. And so I was gonna just sort of help you maybe whittle that list down to at least in my, North America or in kind of the central United States, maybe what comes up fairly frequently. But I think you should think about your own geography, your own demographic, and maybe tailor your differential accordingly. So in terms of workup or testing to consider, I'm by no means saying you need to test for every single thing I just listed, but I think any patient with optic neuritis probably deserves an MRI for a few reasons. One is to demonstrate optic nerve enhancement and help solidify your impression. Number two is that you can learn about clues as to what the optic neuritis could be from simply based on the pattern of enhancement that you see on the scan. Number three is it can help you see if there are other evidence of demyelinating disease, particularly things like periventricular white matter lesions, such as in multiple sclerosis. And it also allows you finally to rule out things mimicking it, whether that be a brain tumor or something else going on. And I listed a lot of labs here that you could think about getting based on your differential diagnosis. I think that toward the top is what I usually will at least get with a pretty low threshold. Including NMO IgG and MOG IgG in particular, because those entities have different prognosis, different responses to treatment, and different therapies as compared to your typical optic neuritis. And then I think you could have a selective implementation after that of additional testing based on what you're suspecting. So I wanted to run through a few case examples with you in the few minutes I have remaining to hopefully apply this sort of thought process. So for case one, we have a 22-year-old Caucasian woman. She has subacute painful loss of vision. She has a headache that she describes as behind her eye and maybe around her eye. And she says this all started about 10 days ago and has since pretty well stabilized, but she's still somewhat uncomfortable. Best corrected visual acuity is 2200 in 2020, and she has an RAPD on the right eye. So who thinks this is typical and who thinks this is something like a zebra, that we're dealing with something really, really unusual? If it's typical, raise your hand. Yeah. So you're doing your assessment. You ask her, okay, look at this bottle of tropicamide. How does it look? And then look at it with your left eye. And she's like, oh, yeah, it's blurry, and it's not as red. So that's just highlighting the dyschromatopsia that can happen in optic neuritis. You get a visual field, and there's diffuse depression of the visual field. So this is so far just textbook optic neuritis. You look at the fundus. There's mild optic nerve swelling, but really pretty unremarkable. And if you were maybe routinely examining this person and just glossing over the optic nerves, you might even say that that's normal. So what workup would I get on this patient? This is looking exactly like that small subset of the differential diagnosis of typical optic neuritis. I'm thinking in this person, young woman, Caucasian, this is either MS-related optic neuritis or it's just idiopathic isolated optic neuritis. So what would I get? I would get an MRI brain and orbits with and without contrast, and I would ask the radiologist to do fat suppression techniques on the orbits so you can really see the optic nerve. And that would probably be my starting test, and I would just see what I get back from there. So in this patient's case, you can see on the left, on the coronal sections, the right optic nerve certainly is enhancing as compared to the left optic nerve. And you see it's the intraorbital optic nerve, sparing of the posterior optic nerve. And it's a little bit of a lengthy segment, but it's still, I would argue, less than half of the length of the optic nerve. This is a pretty characteristic radiographic appearance of what we call typical optic neuritis or MS-related optic neuritis. So not only did we want to know that, but we wanted to know what does the rest of the brain look like. And unfortunately, in this patient's case, she had enhancing periventricular lesions as well as some flare hyperintense, more chronic lesions. So what does this tell us? This tells us this patient probably either has multiple sclerosis or they're at risk of developing multiple sclerosis. I routinely get these antibodies when I'm dealing with a new diagnosis of optic neuritis, again, just because I want to make sure I'm not mistaking something that I think might be MS when it's in reality NMO, because the two have very different treatment requirements and very different prognoses. So in this patient's case, both of these were negative. So we wound up treating her with very high dose bioequivalent oral steroids. As expected, she improves over time. We referred to neurology. She was ultimately diagnosed with MS. And I wanted to just comment on that briefly, just to remind us, the ONTT, the optic neuritis treatment trial, with the 15-year follow-up study, we learned a very helpful fact that patients with optic neuritis who have at least one MRI lesion at the time of onset of their optic neuritis in a 15-year follow-up time frame have a 72% chance of developing multiple sclerosis, whereas patients with no white matter lesions at the time of optic neuritis have a relatively low risk, 25% at 15 years. And if they make it 10 years without a diagnosis of MS, that risk actually drops down to 2%. So very good thing to know when you're counseling a patient, hey, do I have MS? What does this mean? Because patients will go home and Google optic neuritis and read about MS, and you might want to know these sort of pearls for them. The prognosis of optic neuritis and MS is pretty good. 72% of patients had 20/20 vision or better, and over 90% had 20/40 vision or better. A lot of times patients have persistent contrast sensitivity issues or dyschromatopsia, but at least in terms of visual acuity, the prognosis is very good. And in this patient's case, in follow-up, her visual field almost looks completely normal again. So let's move on to case 2. So we have a chief complaint of bilateral vision loss. This is a 33-year-old Mexican man who was visiting Oklahoma for work. He experienced a 2-week subacute loss of vision in both eyes, left eye worse than right eye, and he had pain. And we were talking to him about his problem. He indicated this had happened to him 3 previous times in his life, treated with steroids in Mexico when this would happen. He never felt that he got much better, and he claimed this was worked up and was negative in the past. So red flags everywhere here that this isn't the same as the last case, right? So we look at him. He has 2200 vision right eye, bare light perception left eye. He has an RAPD left eye. We couldn't even perform a field on his left eye because his vision was so poor, and he had pain. And his right visual field is shown. Look at his fundus. Interestingly, he has a pale nerve in the better seeing right eye and a relatively unremarkable nerve in the left eye. So this tells me left eye acutely is upset, right eye chronically has been injured. We get an MRI as expected and as would be very appropriate. And you can see the left optic nerve in particular is enhancing. And this is what I see as a red flag in this case, not only the history and bilateral findings, but he also has chiasmal enhancement. And if we move over to our axial sequences, you can see in the left panel, nearly the entire length of the optic nerve is enhancing from the globe into the intracranial space. And you also see chiasmal enhancement with posterior optic nerve enhancement on the right side. So these radiographic findings are red flags for neuromyelitis optica. The bilateral onset didn't get better with steroids, has profound optic atrophy in one eye, and now has bilateral disease burden yet again. We worked him up really thoroughly, being that this was like unusual, and it turns out he has NMO, and he had positivity of NMO IgG. I wanted just to comment on NMO really briefly. This isn't going to be an extensive discussion of this disease, but it's important to know about this illness, and it's really important to identify it as early as possible because it can be deadly, let alone devastating to the patient's vision. So this is a condition I check for basically on every new optic neuritis patient. Even if I think it's MS, even if I think, or just isolated, I still get NMO antibodies because the earlier you diagnose this disease, the better for the patient. If you misdiagnose them with MS and they get treated with MS drugs, that actually can make their prognosis worse. And so this is a condition I think you should routinely just be checking for this if you have a new case of optic neuritis, particularly in a patient who is of a demographic other than sort of European or Caucasian ancestry. This was a young man from Mexico. NMO spectrum disease is much more common in populations from Asia or the sub-Asian continent or in Caribbean populations. It's much, much, much more common than MS. And so you might want to just know that and tailor your workup accordingly. This patient wound up getting, we'd sent him to the ER from clinic. He got admitted under neurology, was started on high-dose IV steroids without improvement, wound up having plasma exchange. He got modestly better before being discharged, and then he wound up going back to Mexico, where he was originally from, to live with his family. So it was kind of a not that great of an outcome, but I hope he's doing well. So. I'll move through these last few quickly just because I'm running out of time here. So this third case is a 19-year-old Hispanic female. She comes in with left eye pain, worse with eye movements. The eye pain about 3 days later led to vision loss, or she had associated vision loss. She also described positive dysphotopsias, which are not that unusual of a report from patients with optic neuritis. She went to a local ER where they did an MRI, saw abnormalities on the MRI and wound up putting her on oral prednisone, and then was discharged with recommended follow-up with ophthalmology. Interestingly, she said even just after about 1 day of using the prednisone, she felt like her vision was better, which again, great, but that's a little unusual. And so we were seeing her in this context. She had reduced acuity in the left eye with an RAPD in the left eye. Visual field, again, largely diffusely depressed, but denser inferiorly with a overall normal right visual field. Fundus exam shows a rather prominent amount of optic nerve swelling beyond what I would be comfortable just saying is kind of typical for MS or idiopathic optic neuritis, and the fact that her steroid response was so rapid. So this is a case where I'm thinking, this is a little unusual, what could this be? We look at her MRI that she brought with her from the ER. On the left optic nerve, yes, it's inflamed and enhancing, but notably there's perineural enhancement and a little bit of fat stranding around the optic nerve as well, which was an important clue. And so ultimately we worked her up and she was diagnosed with anti-MOG antibody disease, or MOGAD. Just briefly on this entity, MOGAD is a newer recognized disease that's phenotypically distinct from MS and NMO. It's associated with this antibody called anti-MOG IgG. It tends to cause optic nerve edema, and it tends to, or at least has a higher odds of causing bilateral disease. Our patient was unilateral, but if you see a patient with bilateral optic neuritis, this is one that definitely comes up. Patients tend to be very responsive to steroids. Their vision usually improves really impressively with steroids. The biggest thing with MOG antibody disease is that they have a significant chance of recurrent optic neuritis in as many as 30% of patients, and maybe even higher than that depending on what series you read. And so sometimes they wind up having to be on chronic prednisone tapers or immunosuppression on a long-term basis. This disease actually has a fairly good visual prognosis. Patients usually achieve 20/30 vision or better, but it's an important one to know about, especially when counseling the patient about their prognosis. Do you have MS? What kind of treatment do I need, et cetera? She, as expected, had a good outcome with no recurrence up to this point. The last couple I'm just going to whip through really quick. The slide won't advance for some reason. I don't know if this thing ran out of batteries or... If we could just advance the slide. Okay, thank you. 18-year-old female. She comes in with painful loss of vision, count fingers in the right eye with a secocentral scotoma and an RAPD. She said she had some pain for a couple of days beforehand. In this case, we look at her fundus, and yes, there's optic nerve edema, but there's also a macular star. So this is a sign that this isn't just your conventional optic neuritis. This looks like neuroretinitis, which itself has a differential diagnosis that often overlaps with optic neuritis. I started questioning her, have you traveled anywhere? Do you go camping? Have you been bitten by any ticks? And as a typical high schooler, 18-year-old, she's like, no, doesn't elaborate, no, just very dry answers. Do you have any cats? Yes, I have 5 cats. And no multifocals for this patient, let alone she has neuroretinitis, but she fails the cat test. And have you been bitten or scratched? Probably. And so she was positive for Bartonella IgG. This was a pretty straightforward case, but I think it's just shows just that this is a common entity. Bartonella is by far the most common identifiable infectious or para-infectious agent you'll see that can cause neuroretinitis. There are a lot of others listed, but in our population of patients, neuroretinitis is usually from Bartonella henselae. I also usually check for syphilis. In inappropriate patients, maybe Lyme disease. A lot of patients also have idiopathic optic neuritis, where it's just related to a viral infection. Patients usually have good visual outcomes. There's no proven role for steroids or antibiotics. However, the caveat to that is in an immunocompromised patient, you should probably treat them with steroids if they have a Bartonella, antibiotics if they have a Bartonella infection. My last case I'm just going to mention really briefly and then I'm done. This is a 43-year-old Caucasian man who came in with bilateral eye pain that started over a year ago, and his vision has been continually getting worse, and he was referred to me actually for papilledema. He had 20/50 acuity right eye, 21/50 acuity left eye, RAPD left eye. Visual fields look terrible in both eyes. Red flag here. Anteriors, I usually just go right to the fundus, but I couldn't help but notice his pupil looked a little funny. Posterior synechia with AC reaction. He has hazy vitreous. He has optic nerve edema in both eyes, but the view was cloudy. He had vitritis. This is not papilledema from IIH, which is what he was labeled as having. This is, number of things telling me that's not what this is. Turns out he had syphilis. After taking a social history, he shared with me he was recently divorced and was just living a rock star lifestyle, making a lot of decisions that maybe he regretted eventually, but he wound up having syphilis. He was treated with 14 days of IV penicillin with a really impressive improvement and resolution of his optic nerve edema. So just always remember syphilis. So anyway, thank you.
We have time for one question, probably.
For your treatment of the typical optic neuritis patient, the first one,
Yes.
used high-dose oral steroids for 3 days. Can you comment on that versus IV for 3 days and then the 8 days of follow-up with oral?
So our treatment of optic neuritis was, the ONTT really helped establish that IV methylprednisolone, 1,000 milligrams a day, usually divided Q6 hours for 3 days, followed by a prednisone taper. That was the protocol used in that study. That can be, I guess, from a practical perspective, patients can't, it's not easy always to admit a patient and have them go to the hospital for three plus days to receive that treatment. And so there's been a little bit of a movement toward using bioequivalent, very, very high doses of PO prednisone that achieve the same level of corticosteroid in the patient's system without having to have an IV and being administered through that route. So I quoted a couple of papers on that slide that described this treatment modality as being effective for improving visual function in patients with optic neuritis. And so my partners and I often employ that treatment modality if the patient desires treatment at all, and that's a conversation in and of itself. So that's not that uncommon of a treatment modality. Actually, in my practice, as well as even neurologists on my campus, will use that instead of asking the patient to be admitted for several days. I guess if there was a concern about that treatment route, you could also, and I've done this too, you can arrange maybe treatments at an infusion center where they go in and maybe have a pulse dose of steroids for 3 days. The taper of the prednisone is something that you don't necessarily have to do, but some providers will put the patient on maybe 1 milligram per kilogram equivalent after the very high dose and taper by 10 milligrams every other day thereafter. But usually when it's such a short high dose treatment duration, that's not always necessary. Did that answer your questions? Okay. And the doses we were talking about are different from just 80 milligrams of prednisone. That was in the ONTT found to be associated with a higher rate of optic neuritis relapse. The doses I was talking about are 625 milligrams twice a day, which is like 50 pills at a time. Pharmacies often balk at that and they're like, what are you talking about? But it's effective, so.
Thank you so much.
Thanks.
Yep.